Welcome everyone, Dr. Naveen here from UPSC MEDICO. In this video, I'll be quickly discussing the key for UPSC CMS 2025 paper. In this particular video, I will be focusing on the subject Pediatrics. Now it contains 24 questions as you all know. Among the 24 questions, this time around almost 18 questions were multiple completion type. Multiple completion type in the sense you would be given 4 different options and you have to choose correct set of options from these. And also one area, instead of asking you 3 correct set, this time around almost more than 50% of the questions there were only 2 options which were correct. Now the examiner tried to make this pediatrics part little on the difficult side because we could sense it from 2 things, that the aspirants felt it a little lengthy and also multiple completion type questions. Now instead of ruling out one option, you have to rule out 2 options, right? So that could be the reason it was on the difficult side. Apart from that, when you look at the repeats as well, only 7 out of 24 are direct repeats. You see, usually we presume that CMS exam, lot of questions are repeats, maybe from last 5 or 10 years of papers. When you analyze the repeats, there are topics like Genomic, imprinting, IMNCI, Autism, Rashtriya RBSK program, danger signs in IMNCI, again RBSK and ADHD. So when you compare for last 5 years, hardly you could see 6 or 5 repeats. Okay, so overall the topics which were frequently repeated this time around are IMNCI, which again includes the classification of pneumonia, that is acute respiratory insufficiency protocol, and there were questions on developmental milestones, but this time around only 2 questions. Usually they ask 6 to 7 questions from developmental milestones as per the previous year analysis. So a lot of questions from electrolyte imbalances this time, and also of the vaccines. So these are the topics which are frequently repeated. So this time around, instead of asking a similar question, the topics are reported. So that's the point, or that's the analytical insight that you need to carry if you are going to appear for next year, and also for any fresher who is going to write for 2026. Though PYQs will be there, like repeats will be there, those are important, but instead of PYQs, the previous topics are more important, right? So don't just rely on the PYQs and explanations. You need to predict the future pattern and prepare according to this exam. Now look at the level of competition as well. So there was a RTA filed to know the total number of students who have appeared for CMS exam, and this time around the total number of students who have appeared, it is crossing 70k plus. So more than 70,000 applicants have applied for this exam. We do not know how many actually appeared on the day of the examination, but again 70,000 is a huge number, right? But overall analysis, paper was on a little difficult side. So if you felt it a little difficult or easy or moderate, you can comment it in the comment section so that we'll have a fair idea from aspirant mindset. Now as we're done with the analysis part, so what I'm trying to do is I'm going to analyze the number of topics which were asked, and the high yield topics wherein lot of questions came. So I'll be giving you the key, and also we'll be discussing a little more explanation of these questions, because I found these questions little conceptual. So these concepts might help you for future exams, including the NEET PG and INACET. So if you watch it till the end, you get to know a little extra points from the pediatrics as well. Now this is the syllabus which I have taken from the syllabus book given by the UPSC. So from common childhood emergencies, they have asked hyperkalemia, hypocalcemia, hypernatremia. So 3 electrolyte disturbances. Even last year also there was a question on hyperkalemia, little different question. Now even endotracheal intubation, upper GI bleeding, these are like a little in-depth questions, core questions which were difficult for students to answer. Status epilepticus also, they went into asking about the management algorithm part. Now the two questions on status epilepticus. So UPSC CMS, uh, they tend to repeat the same topic in the same exam. Like the same topic, they'll ask two or three questions on the same topic. Basic newborn care, only one question is there. Normal developmental milestones, the weightage has been reduced. There were 5 to 6 questions in the past, but only two questions. Accidents and poisoning, there's no question on accident, but in the poisoning, there was one question. That too, laboratory clues in poisoning. There's no direct question on paracetamol poisoning or salicylate poisoning, but there is a question on laboratory clues in case of poisoning. And this important table from OP guy, I could see that every year there's a question coming up from that particular table. Now, national health programs also related to child health. This RBSK is been keep repeating this. They keep repeating RBSK for almost 4 years now. IMNCI, the three questions, and this time they asked question on POCSO. POCSO was not a recent stuff, right? It's a 2012, which was launched in 2012. The act came into force, but again they asked a question on POCSO. Just they were focusing on the rights of the children. Now, immunization, there was a question on rotavirus, and also there is a question on secondary immunodeficiency syndromes. Now, coming back to birth defects or genetic defects or counseling or recognizing children with special needs, all clubbed together, you have almost 5 questions. One on autism and ADHD, which are commonly repeated questions in this exam. And there were questions on cerebral palsy and genomic imprinting as well. And you all know the importance of genomic imprinting. In INCI exam, they ask like every year there's a it's like the most frequently repeated question, the genomic imprinting part. So this is also a PYQ which was again repeated in CMS exam. Now after doing all these things, so what I could sense that you have to stick to the syllabus. They're not asking the whole pediatrics. You don't have to go and read the whole OPGUI or Nelson textbook of pediatrics. You have to focus on the frequently repeated topic. That's what I did in the recently launched UPSC CMS video course by UPSC MEDICO. We were able to pick the topics which were high yield, and instead of only discussing the PYQs, we were also discussing a lot of predictive questions, and I have input the same in the mock test, and I could see a lot of repeats coming from the mock tests as well. So this approach has worked. I think this is the way to go if you're preparing for 26 or 27 CMS exam, right? Now we'll start with the key. As I said, the detailed answer discussion, the explanations will be uploaded in the course curriculum of UPSC CMS. But in this video, I'll only be discussing the key and little explanation to give you why my answer is correct. Like the choice which I'm going to choose is correct. So I want to justify that. Now the first question, as I said, RBSK has been asked so many times in the past, right? This is like Rashtriya Bal Swastha Karyakram. And this Rashtriya Bal Swastha Karyakram, it is the abbreviation is, the shortcut that you need to remember for RBSK is 4Ds. So 4Ds includes, they're asking questions on defects, they're asking questions on deficiencies, and they're also asking some questions on disease, and finally you have questions on developmental milestones, developmental delays, and this also includes disabilities, right? So overall you have almost 30 different things in it. Little difficult to remember, but again, as they keep repeating the same question, you need to put in little more efforts to memorize this. Now deficiency part, deficiency means iron deficiency, simple, anemia. Deficiency can be vitamin D, A deficiency. We all know vitamin A and D deficiencies are very common. And deficiency means there could be a deficiency on iodine as well. So iodine deficiency leads to goiter. So these are the 4 things that are included in the deficiency part. But the confusion here is, students might confuse this goiter with hypothyroidism. So hypothyroidism has varied causes. You know, the most common cause of hypothyroidism is not iodine deficiency, it is autoimmune. Hashimoto's thyroiditis is commonly seen in the tertiary practice. So iodine deficiency is seen only in the Himalayan belt, right? So iodine deficiency leading to goiter is different from hypothyroidism. So the examiner is focusing on this simple concept. So this hypothyroidism is actually put into the congenital hypothyroidism part of diseases. So it's not a deficiency. Now look at the question. The question is, which of the following are included as deficiency? Vitamin A deficiency, iron deficiency, vitamin D deficiency. So the hypothyroidism is not a deficiency. Hypothyroidism is a disease. So the correct answer is 2, 3 and 4. So I would go for option 4. So I'm discussing set C key here. This is the question paper I got from one of my course student. So instead of going with set number, just look at the question and check whether your answer is correct. And in the comment section, if you find any answer which is wrong, just post it there. I'll recorrect it and I'll post a different option if it is wrong in the comment section, and I'll pin the comments there, so that for all the aspirants it would be easy to check the right answer, right? So this is first question. Now second question is, yes, hyperkalemia. I think there is no MCQ based PG entrance examination without a question on hyperkalemia. Most of the times they'll ask ECG changes or the treatment part. The problem with hyperkalemia is when potassium levels are very high, it leads to arrhythmias. You have to stabilize the heart first. So that's the reason we first give calcium gluconate. Immediately IV calcium gluconate is given in these phases. Then followed by, we have to either remove the potassium from the body, or you either need to push the potassium from the blood into the cell, like intracellular push. So these are the two things that you do. Calcium gluconate, why do we give? We have to stabilize the heart. We have to stabilize the myocardium. Okay, calcium gluconate to stabilize the myocardium. Now to change or to bring in change in the potassium concentration of the body, you can either give insulin, which will push potassium into the cell, or you can also give beta agonists like salbutamol and terbutaline. Okay, even potassium binding resins can be given, but not for intracellular shift, to push it outside, to bind it in the gut and push it outside the body. So potassium resins, insulin, beta agonists, calcium gluconate are commonly given. Calcium gluconate will stabilize the myocardial cell membranes. Now coming back to the options. So the examiner is asking which of the following statements are correct regarding management of hyperkalemia in a child. Even the adult will do the same thing. Now IV calcium gluconate is given to enhance cellular uptake of potassium. No, IV calcium gluconate, we give it to stabilize the myocardial cell membrane. Beta agonists are given to enhance the cellular uptake of potassium. So these two options are wrong. So if these two are wrong, if 2 is wrong, if 1 is wrong, so you're left with option 4. Now let's try to look at option 3 and 4. Regular insulin and glucose given IV to enhance the cellular uptake of potassium. Yes, I agree with this. Sodium binding, that is potassium binding resins are given to enhance total body potassium elimination. This is also right. So my answer is 3 and 4. Right? Chalo. Let's go to the next question. Now, which of the following statements are correct about rotavirus? See, whenever someone says rotavirus, the problem is, see, usually viral infections are the leading cause for diarrheal diseases, and diarrheal diseases are the leading causes for infant mortality or under-5 mortality, right? So that's the reason we give rotavirus vaccine. But before giving rotavirus vaccine, we have to be very careful, because the one thing that comes into picture whenever we discuss about rotavirus is, just remember this, into susception. Very dangerous condition. Okay, so that's the reason when we talk about rotavirus, we have to be worried about this problem of intussusception. We have to be worried about, so rotavirus, intussusception. Try to remember these two keywords, right? So rotavirus vaccine is there, and it's part of rotavirus vaccine is part of national immunization schedule. It's part of national immunization schedule, and this rotavirus vaccine, if there is a past history of intussusception, it is contraindicated. And what rotavirus vaccine we are giving it is orally. Oral rotavirus vaccine is given, and this oral is Rotavac. Rotavac vaccine is commonly given. There were few other vaccines, Rotavirix and other. They are not in the market now because they had more risk of intussusception. Even this Rotavac also has risk of intussusception, but it is very rare. Apart from intussusception as the side effect, this Rotavac can also present with fever. It can also present with diarrhea. So Rotavac is included in the national immunization schedule, and usually rotavirus vaccine, the older versions are not part of vaccine vial monitoring program, that is open vial policy. That's the reason whenever we open rotavirus vaccine, we have to use it immediately within 4 hours of reconstitution. We cannot store it. But now there is a latest update that even rotavirus vaccines has VVM, that is vaccine vial monitor. But for our CMS exam, such a level of update is not needed because questions are copy paste from the standard textbook OP guide. And this, as you could see, that option 2, the vaccine should be used within 2 hours of reconstitution. That is not 2 hours, it is 4 hours. So option 2 is wrong. As I said, it should be stored at 2 to 8 degrees. So this is correct. So there's nothing wrong with this option 1. And as I said, past history of intussusception is a contraindication. Now what about diarrhea? If the child is already having diarrhea, you're giving vaccine to prevent diarrhea. So the vaccine may not be effective because it is an oral vaccine. So it passes in the stool. Common sense, right? So it is better not to give during diarrheal episode. Even polio vaccine also, when we are giving, if the child is having any illness, we'll repeat the doses later. Right? So 1 and 3 are the correct answer. 1 and 3. Option 3 is right answer for this particular question. Right? So done. Let's move on to the next thing. Now this developmental milestone questions, they were asking like it's a favorite question for CMS exam. Little bit confusing as well. So we'll see developmental milestones. Now I'll not be discussing them in an elaborative way, but again you need to know what kind of milestones they asked in this particular exam. So there were questions on language milestone, and there were questions on gross motor milestones, and there were questions on fine motor milestones. Within a question, it's an integrated question. And also they're asking questions on social and adaptive milestones. So as you could see, here there are 2 questions of developmental milestones. Now in this, the first question, in both the questions they're asking age of the child by giving you the milestones. So we'll start with question number 1. So what is that? First, a tower of 3 blocks. Now if you ask me about the tower part, you need to know first it starts with 2 blocks. So 2 blocks, age, please remember, start with 2 blocks. 2 blocks, 15 months. 2 blocks, 15 months. So if you remember this, 2 blocks, 15 months, then this is followed by 18 months is 3 blocks. A child can build a tower of 3 blocks at 18 months. Next, followed by 24 months or 2 years. 24 months or 2 years. Then we'll jump to 6 blocks. Then the 9 blocks, the child can build a tower of 9 blocks at 3 years. So I'm only discussing the blocks part. 2 blocks, 3 blocks, 6 blocks and 9 blocks. So in the question, because they have asked about 3 blocks, the age is 18 months. So straight away you can go for 18 months. Right? So the first itself is giving you a clue. If you know one of the milestone, it's okay. Now running, the child runs. The next milestone what they're giving is the child runs. That means running is a gross motor milestone. So the child runs. It's a gross motor milestone. So I'm talking about first, when is he standing? Stands at 9 months. After standing, then walks alone at 15 months. After walking 18 months, runs at 18 months. Now staircase, walks up and down staircase at the age of 2 years. And tricycle, tri means 3, tricycle He can drive a tricycle at 3 years. So these are the gross motor milestones. So as per our question, as he is running, again the answer is 18 months. Now coming back to social and adaptive milestones. So what social and adaptive milestone they're asking here? Copying his mother while sweeping. Copying his mother while sweeping. So this occurs at 18 months. Copies mother. Copies a task. Copies parents in task. This occurs at 18 months. Okay, then followed by asking for food, sharing toys, playing in a group. Okay, so then they follow. Now finally fine motor is vocabulary of what is this? Language milestone. Vocabulary of 8 to 10 words. Vocabulary of 8 to 10 words. That is a language milestone they asked. Okay, language milestone. Actually this building tower of blocks, I got little confused here. Building tower of blocks is actually key fine motor milestone. So let me erase it here. It is key fine motor, and this is language. So from the language part, the question was vocabulary of 8 to 10 words. Vocabulary of 8 to 10 words develops at the age of 18 months again. 8 to 10 words. So it starts with 1 to 2 words at 12 months. Sentences, I'm not talking about words. Sentences starts at the age of 2 years. Okay, so these are the 3 things that you need to know. So we're done with the question number 1. Then with the same data, you can even guess the age for 3 years also. As I said, the child is riding a tricycle. Okay, so the tricycle is 3 years. Same, copies a circle is 3 years. So what about shapes? Shapes is also important. Copying is also important, right? So copying circle is 3. Copying a cross is 4. And copying a triangle is 5. Okay, so 3, 4, 5. This is very important. Right? So the development of this child is age 3 years. So we're done with 2 developmental milestone questions. Right? Shall we move on to the next thing? So this topic, next question is from basic newborn care. So when the newborn is born, what we'll do, whenever a newborn is born, first and foremost, it is always important to keep the baby with mother unless there is any complication. So rooming in is very important as per baby friendly hospital initiative. There are 10 steps of baby friendly hospital initiative. Among them, rooming in is an important component. So the baby should be kept in a separate area from mother is always wrong, because it is a normal weight. More than 2.5 kg is good weight. Primi gravida, vaginal delivery. So everything looks normal and the child cried immediately after birth. Why do you want to separate the baby from the mother? Just common sense, right? If option 2 is wrong, what about option 1? The baby should be initiated on breastfeeding within 1 hour of birth. Yes, very important. One more aspect of baby friendly hospital initiative. Now the baby should be administered with 0.5 mg. So here is the confusion. Now the 0.5 mg, yes, we do give 0.5 mg, but as per OP guide, it is given for baby weight less than 1000 grams or 1 kg. If the baby weight is more than 1 kg, we have to give 1 mg. So this is wrong. Now the baby should be thoroughly examined for congenital malformations. So we have to do this. So 1 and 4 are correct. So I would go with option 4. As simple as that. Right? Now this is question from newborn care. So from baby friendly hospital initiative, you have to learn a lot about the breastfeeding, the breast milk part, the attachment part, good attachment, okay, best feeding practices, baby friendly hospital initiative. Anything related to breast milk is important for CMS exam, right? So let's go to the next question. So what are the causes of secondary immunodeficiency? So when I talk about immunodeficiency syndrome, there are primary causes and there are secondary causes. The most common causes are always secondary. So secondary is more than primary, or primary is less than secondary. Among the secondary, the most common cause is HIV. We all know HIV can lead to human immunodeficiency syndrome. HIV can lead to apart from HIV, there is one disease called measles, which we are all worried, because our post measles is dangerous. Post measles, the people will have vitamin A deficiency, that is always there, but following measles or post measles state, it leads to secondary immunodeficiency. It is post measles, not varicella. The confusing part in the question which was asked in the exam here is they are giving you post varicella, which is actually wrong. Why? Because post varicella, if by any chance if the patient develops immunodeficiency syndrome, then post varicella there would be herpes zoster, which might manifest because of the late. See, varicella zoster virus, it goes and it stays latent in the ganglion. If a person with chickenpox in the early life, if he develops or if he has any immunodeficiency due to any other cause, he will manifest as herpes zoster with a dermatomal distribution rash, but not vice versa. So post varicella is not synonymous with immunodeficiency. Students might get confused with this point, so that was asked in this particular thing. So if option 3 is wrong, then you don't have to worry, right? So the correct answer is 1, 2 and 4. So option 2 is correct. So apart from measles, what are the other causes? Let me write it down. So measles is there, HIV is there, severe malnutrition. We all know severe malnutrition can lead to immunodeficiency. Nephrotic syndrome, we all know. In nephrotic syndrome, what happens? There is passage of immunoglobulins in the urine as well. There is a protein loss, plasma protein loss, leading to immunodeficiency. Now, in burns case also there is immunodeficiency when it is severe. And there is hematological malignancies also. Hematological malignancies also presents with secondary immunodeficiency. In severe chronic infections like TB also, severe chronic infection, even in TB also, later they'll have immunodeficiency, right? Now the drugs part is important. One we always know is glucocorticoids or steroids. One we always know is immunosuppressants like cyclophosphamide, that is steroid sparing agents, azathioprine. The one which is confusing, always confusing, is this is where most of the students got confused. That is, they have marked diphenyl hydantine. Diphenyl hydantine is phenytoin. Phenytoin is an anti-epileptic. Phenytoin is an anti-epileptic. When I say anti-epileptic phenytoin, the thing which comes into my mind as an adverse effect is gingival hyperplasia, okay, and patient will have ataxia. Even phenytoin also can cause immunodeficiency, which is not mentioned in the regular pharmacology, but research based, and also in OP guide it is mentioned that it is one of the secondary cause of immunodeficiency. Among the drugs, they have mentioned it as diphenylhydantine, and that micro point the examiner focused it. So diphenylhydantine can cause secondary immunodeficiency, severe malnutrition can cause it, nephrotic syndrome can cause it. It is not post varicella, it is post measles. It is post measles, right? Now, next question is, which of the following statements are correct regarding vaccination routes for children? Okay, vaccination routes for children. Now, hepatitis B is given after birth. There is birth dose also. So we give it IM. When we give it IM, we will not give it in like gluteal region. Even in adults, even if you take hepatitis B vaccine, it is not given in gluteal, because gluteal region there is reduced absorption, so it decreases efficiency. So when you know this point, you tend to confuse deltoid with gluteal. Hepatitis B vaccine is given in deltoid region, so this statement is wrong. If this word is gluteal, then this statement is correct. So I would go this as a wrong statement. Two vaccines may be given in the same thigh but separated by 1 inch. Yes, you can give it. You can give it. So that's the reason when a newborn goes to, there would be a pentavalent vaccine which is given in IM. Apart from that, they would give one more injection as IM. So if needed, 2 injections can be given on a similar thigh, but we have to keep 1 inch apart distance to check for anaphylactic reaction, skin related reaction. Now, separate sites are used when administering a vaccine and immunoglobulin. This is also right. You know why? Why? Because if you give a vaccine, it will produce antibodies. If you give IVIG, so that will be neutralized. So there is an antigen, there is an antibody. So there is antigen coming from the vaccine, there is antibody which is given in IA. So chances of neutralization are high. So we will follow this principle during rabies post-exposure prophylaxis. So we will give RIG, that is rabies immunoglobulin at wound site. We will give vaccine intradermal at separate site. We will follow the same thing during hepatitis B prevention, that is transplant prevention of hepatitis B infection from mother to child. Immediately after the birth, the baby will receive both IVIG and also the baby will receive vaccine, but both at different timings or different sites. So these two are correct answers. Two IM vaccines may be given on the same day but in separate limbs. No, you can give same limb. So if this is correct, simultaneously or vice versa, this is wrong. So the correct answer is 2 and 3, that is option 3. Now from the poisoning, there is a question. Radioopaque density was noted in poisoning in which of the following thing? See, laboratory clues in poisoning, this table is like examiner favorite table from OP guy with regards to the toxicology. So anything can be a question, and there were so many previous year questions on that. But this time around, he is asking about radioopaque densities. So in a case of poisoning, rarely we do X-rays. But when you do an X-ray, if you note radio opacity, then we will be looking at some of the components. That is, one, we all know iron is radioopaque. So in iron poisoning, you will see that. Any heavy metal, I'm just mentioning the easy parts. Any heavy metal can have the same thing. And patient might have taken tablets which are enteric coated. So enteric coated tablets will also show you, radio opacity. Any dental amalgam, okay, any dental or amalgamous tooth which was ingested will have a radio opacity. Apart from that, we have calcium carbonate, we have chloral hydrate. This was the question they asked. Radioopaque density. I think it is little tough to remember, man. Like you can't remember chloral hydrate, calcium carbonate, right? Little different. Even potassium chloride. So I'm safe. I'm on the safer end because I'm not writing this exam, but I pity you because you have to remember this to score 1 mark in this. Chloral hydrate is radioopaque. Iron is easy. Iron, heavy metals, enteric coated tablets, even dental amalgam. Even you can even say that drug abuse. You have surgical mules. They ingest drug in the polyethylene packets, right? So they can also be seen in the X-rays. Surgical mules for drug trafficking or drug transport, smuggling. So these are the radioopaque densities. So I would go with answer chloral hydrate, right? Option 4. Direct question from the standard thing. See, this is a dead easy question. Like, what is genomic imprinting? We always have two things with genomic imprinting. Most of the times the question is a repeat. We have Angelman, we have Prader-Willi. So just mark them, Prader-Willi and Angelman. Done. Right? So what are these other options? Edwards syndrome is a trisomy. And even Rubinstein-Tauby is a gene deletion syndrome only. Gene deletion syndrome. But not because of genomic imprinting. This is not because of genomic imprinting. When I talk about Prader-Willi syndrome, Prader-Willi, I am talking about microdeletion on Prader-Willi, P, on paternal side. So this is vice versa. Angelman is mother, that is maternal side. Angel, mother. Microdeletion on maternal side. Okay? Microdeletion on maternal side. Now, we have in the Prader-Willi we have symptoms like hypotonia, because next time they might give you a clinical manifestation. mental retardation will be there, and obesity will be there. Prader-Willi will be obese, and this deletion occurs in 15q11. Coming back to Angelman, yes, here also we have a micro deletion on maternal side because it's a gene deletion syndrome, right? It's a gene deletion syndrome. Apart from that, we have Rubinstein-Taybi syndrome. Rubinstein-Taybi syndrome. This Rubinstein-Taybi syndrome is a gene deletion syndrome. It is associated with microcephaly, broad thumbs, microcephaly, broad thumbs, big toes, facial dysmorphism, and mental retardation, and this is because of 16q13. This is because of 16q13. So we're done with genomic imprinting, and also some of the there are other gene deletion syndrome also which can be asked in the future. It can be a Williams syndrome, can be a gene deletion syndrome, and even Dijorge syndrome is also a gene deletion syndrome. So my correct answer here is 2 and 3. Prader-Willi and Angelman are genomic imprinting. Now this they should not have asked because it is very rare, like POCSO Act. We all know about POCSO Act in movies, but like they have asked a specific question on POCSO Act, that is, if there is a sexual assault on children, that is age group less than 18 years comes under POCSO Act, when it is considered aggravated is the question. So the aggravated comes when the abused child is a disabled child, if there is any mental disability from the abused child, and also if the abuse is done by guardian, like not a family member or a relative. I'm not talking about even a guardian appointed by a family member. That is not an aggravated sexual assault. As per POCSO, if it is committed by either police, if this is committed by either police or an army personnel or doctor or any management staff of the hospital or any educational institute, principal or teacher, so then we consider it as aggravated. So disabled and police. So the correct answer here is option 3, that is 2 and 3. Right? Now next. Now there are 3 questions on IMNCI. First we'll finish off IMNCI based questions. See, IMNCI, Integrated Management of Neonatal and Childhood Illness, very important because I teach for UPSC Civil Services Examination Medical Science optional as well. It is very important because pediatric essay answers, whatever disease they ask, we have to approach it in an IMNCI based manner, right? So for that reason, I teach them a lot. But this IMNCI is never asked in our regular exams, that is NEET PG and INA-CET exam. There they will be focusing more on WHO or curative way. We have WHO Acute Respiratory Insufficiency Protocol. So this protocol and also IMNCI protocol for pneumonia, that is not pneumonia, actually in IMNCI we have 2 months to 5 years age group, wherein we ask for difficulty breathing or cough symptom. So we will evaluate this symptom. So in either of the case, here in ARI protocol we have cough. Okay, in either of the case we look at fast breathing. If the fast breathing is present, fast breathing means respiratory rate, right? If the respiratory rate is more than 40 in case of age more than 1 year to 5 year child, if it is more than 50 in case of 2 months to 1 year, if there is more than 60 in case of 0 to 2 months, then we call it as fast breathing. If fast breathing plus lower chest indrawing, if it is present, we call this as pneumonia. It's as simple as that. On top of that, plus on top of that, there is a severity classification. This severity classification is different for ARI protocol by WHO, and this severity protocol is different as per IMNCI. You know what, in IMNCI, this severity protocol, let me go to that particular question. This severity protocol in IMNCI, I'm talking about a child of 4 years presenting with cough or difficulty breathing. Anyway, I'll be asking question on respiratory rate more than 40. I'll be looking at chest in drawing. If these two are present, I'll call it as pneumonia. But question is, which of the following are signs of severe pneumonia or very severe disease? This is what they are asking. Severe pneumonia or very severe disease, there are two criteria for it. One, if there is any general danger sign. What are the general danger signs you see in any child? The child is vomiting everything, whatever he is eating is a general danger sign. And the child is under convulsions is a general danger sign. Convulsions, presence of convulsions is also a general danger sign, right? So these are the two general danger signs which are mentioned in IMNCI. Apart from that, if the child is not able to drink, if the child is small, not able to breastfeed also matters, not able to breastfeed. And if the child is lethargic or unconscious also is a general danger sign. If these are present, then automatically we'll say that the person is having severe pneumonia or very severe disease. And the other criteria is any stridor in a calm child itself is a danger sign. So the correct answer here is 2 and 3. So we're discussing IMNCA questions. I went far ahead. I first want to discuss about the presentation. So there are varied presentations. In IMNCA, they have divided into 0 to 2 months as a separate entity, 2 months to 5 years as a separate entity. Most of the time they'll ask questions on 2 months to 5 years. So in this 2 months to 5 years, before getting into anything, first we have to ask about general danger signs. And if these general danger signs are present, this is risky. Because if there is a general danger sign, immediately we have to refer to hospital. Urgently we have to refer to hospital. One problem is done. I am talking about pneumonia is done, or cold or difficulty breathing is done. If I talk about any child who is presenting with ear pain or discharge, or to be frank, let's call it as an ear problem. So in this question, they're saying that there is a child presenting with 3-year-old with ear problem. Then what to do? See, as per MNCI, in a 3-year-old presenting with ear problem, the danger sign that you need to look at is pain behind ear. If there is a pain behind ear, it points towards mastoiditis, and this child requires immediate referral, because mastoiditis requires surgical exploration, drainage before giving antibiotics. But if the child has pus draining from ear and this is acute, that means less than 14 days, I'm talking about any acute ear infection. I'm talking about any acute ear infection. So in that case, what we need to do, in acute ear infection, we have to give acute ear infection, we have to give antibiotic, that is amoxicillin, for 5 days. Okay, we can also give, if there is pain, if there is ear pain also, we can classify it as acute ear infection. We can give painkiller as well. If the pus is draining but it is more than 14 days, then I am talking about chronic ear discharge. So any chronic ear infection, we don't have to straight away give oral amoxicillin. We can give topical, that is ear drops with ciprofloxacin, and we can advise ear wicking, like dry the ear by wicking, and follow up is advised. So these are the two criteria. Coming back to the question, in a child 3-year-old with ear problem, which of these situations merits urgent referrals? Pus seen draining from the eye, discharge reported for less than 14 days, just give oral antibiotics suffice. Pus draining from ear, discharge reported for more than or equal to, that means chronic ear infection, we have to advise topical ciprofloxacin drops. Tender swelling, yes, this is dangerous. Any tender swelling, we are looking at mastoiditis, so immediately refer. So my answer is option 3 here. Okay, my answer is option 3. So we're done with 2 MNCA based ones. Let's go back to the third one. This is again tricky. I think they shouldn't be asking this. If there is any student who is listening to this class and who is also preparing for UPSC CSC medical science optional exam to become an IAS or IPS, for them we all know that IMNCI is an important topic, and if you want to expect any unasked question, this question can be a potential question, because here they are asking about advice to mother, that is counseling. So that too, you're counseling mother about two important things here. What are you counseling the mother here? You're going to counsel the mother on two important things. One, about feeding, and second, about support for development. Support for development. You have to advise that, and this advice is divided into different age groups. One is 0 to 6 months is different. 6 months to oh, like let's say um, 9 months is different. 9 months to 12 months it is little different. Okay, then 1 to 2 years it is different. 2 to 5 years is different. So advice is different at different age groups, and there is a beautiful table in the last pages of OP Guide for IMNCI. Therein they have differentiated the advice that should be given. In the regular part of discussion for our course, I will be discussing all these things in greater detail, but we'll come back to the question what they're trying to ask. Here they're asking you, there is a 14-month-old normally developing baby for feeding advice. So breastfeeding should be done for 2 years, right? So 14 months. So breastfeed as often as child wants. This is correct. Keep the child in your lap and feed with your own hands. No. Till 1 year only we have to feed. From 0 to 6 months, exclusive breastfeeding. So don't worry about feeding with hands. 6 months to 1 year, feed with hands. Feed with mother hands by sitting in lap. 1 year to 2 years, support. After 2 years, individual. He has to eat on his own. So this is wrong. Offer fruit from family pot, very important. Give 3 to 4 meals each day and 1 to 2 snacks. This is also correct. So the wrong option is option 2. So overall the correct answer is 1, 3, 4. So I would go with option 2 here. Right? Option 2. So the next part, what I'm going to discuss is about status epilepticus. Status epilepticus, very important. When do we call it as a status epilepticus? Status epilepticus, we call it any seizure. Like you are a casualty medical officer now, or you are an inter poster in casualty. If there is first time seizure, 50% chances, unless the patient is known epileptic on any anti-epileptic therapy, 50% chance that it can be status epilepticus. That is the reason we tell all our juniors, if there is a case of seizure, go and treat it as a status epilepticus. Go and treat it as a status epilepticus. When you're treating the patient, if the patient is responding within less than 3 minutes, then it's fine. But even after giving 30 minutes of treatment, it is persisting. Multiple seizures are coming and going, and there is no regain of consciousness in this 30 minutes of time, then I'll call it as status epilepticus. Till now it's okay, right? Status epilepticus, this is what we need to do. So I said any case of seizure, let's presume that it is status epilepticus. If he presents to a casualty, you have to start treatment. Seizure is a childhood emergency, so that's why ABC is important, that is airway, breathing, circulation, and we have to give oxygen supplementation. We have to send investigations, because most of the time seizures can be because of hypoglycemia, so that's the reason we send RBS immediately. It can be because of hypocalcemia, so electrolyte imbalances, we send for serum electrolytes. Apart from that, we do tests. We will discuss this in detail in the regular class. But what is more important is, immediately we have to start with either IV lorazepam, or you can even go for IV midazolam. But these are stat, that means you have to give only one injection. Okay, the dosage is important because they have asked a question on dosage also. 0.1 milligram per kg. So you can give one dose stat. If patient doesn't respond in 5 minutes, you can give one more dose. So total 2 doses can be given. So IV lorazepam, IV midazolam. So you're giving 5 minutes apart 2 doses. The patient has presented to you. Within 5 to 10 minutes, you have already given 2 doses. If the patient responds, it's fine. At the same time, we have to correct if there is hypoglycemia, hypocalcemia, etc. Even after doing this, if seizure is continuing, then we'll start anti-epileptics like IV, because we have started with benzodiazepines only. We are not giving anti-epileptics. First we'll give benzodiazepines first. Second we'll give anti-epileptics. So the anti-epileptic which we prefer is either IV phenytoin or IV fosphenytoin, or you can give sodium valproate also, or you can give levetiracetam also, or then we can go for phenobarbital coma. Or we can even give IV midazolam. Instead of a single injection, we can give infusion, that is 1 to 15 microgram per kg. See, all these phenytoin, sodium valproate, levetiracetam, phenobarbital coma, midazolam, all these are infusions. They are not stats, they are infusions. Now you see, midazolam IV stat is different. Midazolam IV infusion is different. Midazolam IV infusion is given in ICU setup. It is given when all these are not working. It is a sequential order. We'll start with IV lorazepam or midazolam, start dose followed by 5 minutes, one more dose. Then we'll start infusion if the patient doesn't respond. You can go for phenytoin or IV fosphenytoin, sodium valproate. Then you can go for levetiracetam. Each 5 minutes you can shift. Then you can start with phenobarbital, either coma, or you can put IV midazolam, right? Or if the patient still not responding, see, first we'll give phenobarbital injection only. I'm so sorry. Then we can go for IV midazolam infusion, or we can go for phenobarbital coma. This can be given by phenobarbital, or you can even use thiopentone or propofol coma. So coma, midazolam infusion, phenobarbital coma, or then we can go for IV ketamine plus oral topiramate. IV ketamine or oral topiramate can also be given at the end. If nothing comes in handy, we can go for IV ketamine and oral topiramate also. This is confusing. Why oral has come into the picture? So this question is asked in this CMS exam. Now coming back to the management algorithm, any seizure considered as a status epilepticus if he is not responding for more than 30 minutes of treatment, and also if he is not regaining consciousness, then I will be worried that it is status epilepticus. Then there are two terminology that you need to understand. What is refractory status epilepticus and what is super refractory status epilepticus? We know what is status epilepticus, that is more than 30 minutes. Refractory means patient has started this epilepticus and I am giving first benzodiazepine 2 doses, plus I am also giving IV fosphenytoin. Even after that patient is not responding, I will call it as refractory status epilepticus. That means at this stage. Now the patient is not responding even after admitting in ICU, even after giving 24 hours of anesthesia. That's the time you go for either IV ketamine or oral topiramate. So this case where even after giving 24 hours of anesthesia the patient is not responding, that is super refractory status epilepticus, which is treated by IV ketamine plus oral topiramate as last resort. So that's the question they have asked in the exam, that is, which one of the following oral drugs may be used in management of super refractory status epilepticus? To understand this, you need to know what is super refractory status epilepticus and which drug should be given. So clonazepam, no. Clobazam, no. Lamotrigine, topiramate. So oral topiramate is my answer for you for a super refractory status epilepticus. There's one more question on status epilepticus. Which of the following statements are correct regarding benzodiazepines? I am giving IV lorazepam, IV midazolam either as a start dose or as an infusion. So keep these points in mind. We'll solve this question. Up to 2 doses may be used 5 minutes apart if seizures are not controlled. Yes, as I said, you can use the stat also. For lorazepam, only single dose. No, even lorazepam also you can give 2 doses. The dose of midazolam at this stage is 1 to 15 microgram per kg. No. This 1 to 15 microgram per kg infusion is given when Everything doesn't work in an ICU setting. So this is wrong. So the dose of midazolam is zero point 0.1 mg per kg stat. So the same thing, dose of both lorazepam and midazolam, this is true. So the correct answer for this question is 1 and 4. Option 2, 1 and 4. I think little conceptual, right? I like it, these questions, because any emergency, childhood emergency, they're asking in depth. I think if you know these answers, the similar questions can be framed as your interview questions as well. They'll ask you if there is a seizure case in front of you, how will you manage? They'll ask these kind of questions in the interview. They'll not ask something else. Like they will ask the same syllabus oriented questions, common childhood emergencies, if they want to ask. So in this childhood emergencies, there's the next question, that is hyponatremia. But when they ask any question on electrolyte imbalances, they are focusing more on causes. So in this, they are asking diabetes insipidus can be a cause of hyponatremia. Yes. Addison's disease, no. Addison's disease causes hyponatremia. It is actually hyperaldosteronism which causes hyponatremia. So this is wrong. Right. Similarly, use of boiled skimmed milk can lead to hyponatremia. Yes. Use of lactulose can lead. Yes. So 1, 3 and 4 are correct. 1, 3 and 4 are correct. Just simple question. I think I don't need to discuss at all, because any cause, see, causes of, please remember, hypocalcemia, hypercalcemia, hypokalemia, hyperkalemia, hyponatremia, hypernatremia. They will ask these questions for sure. Even magnesemia also, hypomagnesemia, hypermagnesemia, hypophosphatemia, hypophosphatemia. You have to be ready with the causes on your fingertips, because every year 1 or 2 questions are coming in this segment. As we're discussing acute childhood emergencies, one of the emergencies, upper GI bleeding. Upper GI bleeding. Whenever you see a case of hematemesis or upper GI bleeding, you should be trying to identify the cause. You should be able to localize the bleeding site by doing endoscopy. You have to stop the bleeding. For stoppage of the bleeding, you can either go for vasoactive agents, like you can go for somatostatin or arcuate infusion, or you can go for endoscopic sclerotherapy. There are two options which are available. Anything can be used. After control of the bleeding, you have to go for secondary prophylaxis for sure, because there are increased risk of rebleeding. So option 4 is correct. Following an episode of acute varicose bleeding, all patients should receive secondary prophylaxis to prevent bleeding. So what is this secondary prophylaxis? Secondary prophylaxis, most of this time, is we do endoscopy and we do ligation. We can go for endoscopic sclerotherapy, etc. Actually, somatostatin and arcuate infusion should be given for at least 7 days after stoppage. No, we have to start initial. This is initial bleeding. You won't use this somatostatin or arcuate infusion for rebleeding. Endoscopic sclerotherapy can be used. It includes endoscopic injection of N-butyl 1,2-cyanoacrylate or isobutyl. See, these are wound adhesives. These are not sclerosants. Sclerosants are altogether different entities, right? So what is that sclerosant which we use for during upper GI endoscopy? What is the sclerosant which we usually inject? It is 1% ethoxyschlerol. I think this looks a little different and difficult question, right? So coming back to the concept again, one thing is clear. This is not sclerosant, it is wound adhesive. This wound adhesive is important from general surgery questions, so this is wrong. Option 2 is wrong. So these two are wrong. Now option 4 is always correct. So because 4 is correct, you can go for 3 and 4. So option 3. EST has up to 90% efficacy. Yes, right. So this is already told you it is wrong. So correct answer is 3 and 4. Are we done? So let's go a little fast, as it is taking more time than usual. So what we'll do is we'll quickly finish off the remaining questions. The detailed discussion I'll be uploading in our course curriculum for all the questions of UPSC CMS 2025 real soon. Now, which of the following are advantages of endotracheal intubation? See, endotracheal intubation, the major advantage is it will protect the airway, but major disadvantage is increased risk of aspiration. To prevent this increased risk of aspiration during endotracheal intubation, we use rapid sequence induction, wherein we give anesthesia and we perform a special maneuver known as Selix maneuver. That is, we apply cricoid pressure. Based on this point, a lot of questions will come in MCQ based exams, including NEET PG and INA CET. So reduced risk of aspiration is a wrong statement because it is actually a disadvantage of this thing. So for me, 1, 2, 3 are correct. I don't even need to look at the options. 1, 2, 3. Option 1. Those are all the advantages. But endotracheal intubation will never prevent the risk of, actually it increases the risk of aspiration. So that's the reason we have to perform rapid sequence induction to perform this, and we need a Selix maneuver, or we have to apply cricoid pressure to prevent the reflux of the gastric contents. Now next, hypocalcemia. So what are the causes of hypocalcemia? Hypocalcemia is caused by metabolic alkalosis, not acidosis. CO2 washout leads to hypocalcemia. Ionized calcium levels decreases. So this is wrong. Right? Pseudo-hypoparathyroidism is correct because any hypoparathyroidism will lead to hypocalcemia. Now we have two options, hypomagnesemia, hypophosphatemia. It is not hypophosphatemia, it is hyperphosphatemia. Hyperphosphatemia means renal failure. In renal failure, you will have hypocalcemia. So this is right, hypomagnesemia and 1 and 4. So the correct answer is 1 and 4. So causes of electrolyte imbalances is very important for your future exams. So we are already done with IMNCI questions. Last we have ASD. It's a repeat question. What are all the genetic syndromes? What are all the genetic syndromes that can be seen in case of autistic spectrum disorder? See, we either call it as autism. We'll not call now only autism because the spectrum is different. Some people will have mild symptoms which they recover. Some kids will have very severe symptoms. So this ASD is a behavioral disorder. Motor milestones, everything is fine. The problem is with language. Okay, so it's a language disorder. The problem is with the behavior. Now in autistic spectrum disorder, if it is because of genetic conditions, 10% of the cases are because of the genetic condition. We call it as syndromic autism. Apart from autism, they will show other syndromic manifestations as well. So what are these genetic conditions? One common condition is Fragile X syndrome. Fragile X syndrome. Now the second one is Rett syndrome. Rett syndrome. Now tuberous sclerosis. So these two options are given here, tuberous sclerosis and Fragile X syndrome. Prader-Willi syndrome is genomic imprinting. Patau syndrome is trisomy. So these two are not associated with autism. So I would go with option 1 and 2. So the other syndromic causes, which was actually, this is not given in OP guy. These genetic causes are given in Nelson's textbook of pediatrics. Okay. So one is Down syndrome is associated with autism. We have phenylketonuria. And we even have Charge syndrome, which is again a genetic cause. Yes, Angelman syndrome. It is not Prader-Willi. Angelman syndrome is associated. This is important. Angelman syndrome is associated with autism. Angelman syndrome. We have Joubert syndrome. Joubert syndrome. And final one is Timothy syndrome. This is the 9 syndromes which are given in Nelson. Okay. So these are autism or autistic spectrum disorder associated syndromes. Right? Let's go to the next question. Now, cerebral palsy, there are two questions. Cerebral palsy, they have asked two questions. One is, so what is cerebral palsy? There is problem with movement, agree. There is problem with posture, and these are permanent. The disability is permanent but non-progressive. That means if patient is born with some X symptom, the X will remain. It is not progressive. Patient will not have increasing symptoms in this case of cerebral palsy. So you should be very aware of this point. So problem with movement, posture and tone, which is not asked in the exam. Even it is a problem with tone. So cerebral palsy is a disorder of movement, a disorder of posture. Yes, it is permanent, but it is non-progressive. Very simple definition based questions, and CMS will ask this kind of questions. So answer is 1, 2 and 4. Where is 1, 2 and 4? 1, 2 and 4. Yes. Right? They made a major change. So, previously in the exams, they used to give options like this, and students, instead of looking it as a multiple completion question, immediately they'll think one is correct and they'll put it in the scribe or OMR sheet. So they will lose marks. So this time around they're using very interesting, that is they're using Roman letters to kill or curb this confusion, right? So cerebral palsy, one question. Second question is, cerebral palsy is characterized by important symptom, that is spasticity, and this spasticity is measured by two parameters or two scaling systems. One is gross motor function classification system, and the second one is modified Ashworth scale. So these are the two things which we use. See, this medical research council system is regular muscle tone, which we measure in neurological examination. Modified Corner scale is used for ADHD. Okay, muscle tone, ADHD. The remaining 1 and 4 are important, and every year I could see that there is 1 or 2 questions on classification systems important. So while you are learning for 2026 or 2027 attempt, if you see any classification system, just make a note of it and try to know which disease it is related to, because there were questions on this part asked multiple times. And final question is ADHD. A lot of times they ask, only remember these two drugs, atomoxetin. Almost 4 times it is a repeat in last 5 years. Okay, methyl phenidate are the two drugs which are used in case of ADHD. So the correct answer is answer 2 and 3. So these are the key solutions, a little bit of discussion for pediatrics. So I'll be doing the similar pattern of discussion, maybe a little fast with regards to general medicine, general surgery, OBG and PSM in coming few days, and I'll be uploading these videos into the YouTube. So if you find any issue with any question or any key answer, just type it in the comment section, and at the same time also comment about the level of difficulty of the paper, your thoughts on the paper, so that we would understand the aspirant mindset, how the exam went. And also one more thing is how you felt about the session, because this is the first time UPSC MEDICO is discussing a solved paper. Actually we have done this as an explanatory part in the regular course, but we haven't uploaded anything into the YouTube. So if you find it interesting and useful, we'd be doing this every year. We'd be discussing the key part solved paper. So because we always think about the quality part, so yes, the videos will be coming, but not dead fast, but accurate, right? So see you again with a few more key based discussion videos in the upcoming days.